Sir, I'll start.
Yeah, please.
50-year-old female patient presented with chief complaints of abdominal pain and vomiting since 1 day. History of present illness. Patient pain in abdomen was present since 1 day. It was sudden in onset, severe in intensity, continuous, and located in epigastric region, radiating to back. Pain increases after food intake and is relieved, slightly relieved after leaning forward position. Pain in abdomen is associated with one episode of vomiting, which was non-projectile, non-bilious in nature, and it containing ingested food. There is no history of loose motion, fever, chronic NSAID use, jaundice, or abdominal trauma. Past history. Patient is a known case of diabetes, mellitus, and hypertension on regular medication since past 14 years. Personal history, there is no history of alcohol intake. Bowel and bladder habits are normal. Patient has no history of previous abdominal surgeries. She has a history of normal vaginal delivery. Family history is not significant. 50-year-old female who came with chief complaints of acute onset of severe epigastric pain radiating to back with one episode of non-projectile, non-bilious vomiting. I would like to consider the following differentials for acute abdomen. Acute pancreatitis. It could be a case of peptic ulcer disease or mesenteric ischemia.
Okay. So coming to the presenting history, presenting complaint, the main presenting complaint was pain in abdomen.
Yes, sir.
And what made you think it is pointing towards the pancreatitis, the type of abdominal pain?
Sir, the pain is located in epigastric region. It was sudden in onset, severe in intensity, and it radiating to the back, sir.
Okay.
Associated with vomiting, sir, which was non-bilious, non-projectile. Patient did not have, sir, any history of abdominal distension or constipation, or neither any history of chronic alcohol abuse or NSAID use.
And this was the first complaint. This is the first episode of our complaint.
Yes, sir.
So this was another thing. And was there any associated constitutional symptoms associated with pain abdomen, which you would like to elicit with this to narrow your differentials?
No, sir. Since like to rule out, sir, patient did not have any tachypnea associated with it. Usually, sir, in DK, patients will have respiratory distress, acidotic breathing, along with pain in abdomen and vomiting. So that is ruled out, sir.
Okay.
Patient of MI can present with epigastric pain and vomiting, but usually associated with sweating and palpitations, sir. So even
Okay.
very unlikely, sir.
And your another differential is acute bowel ischemia.
Yes.
What makes you think one of them is it?
Sir, sudden onset of severe pain, sir, pain in abdomen, along with vomiting.
Okay.
Sir, but patient did not have any history of bloody diarrhea or anything. So I've kept it as a not, sir, very likely diagnosis, sir, here.
Okay.
Hello, Pooja?
Yes, sir.
Hello.
Yes, sir.
Audible.
Cholecystitis, anything? Clinically, you're suspecting cholelithiasis?
Sir, could be.
Cholelithiasis with cholecystitis. What are the points favoring or points against?
Sir, there is no history of fever, sir. And patient did not give, sir, the pain is continuous in nature, sir. Colicky, sir, attacks of pain or colicky type of pain would likely to point towards.
So clinically, how do you differentiate between biliary colicky and pancreatic type of pain? What are the points on clinical history?
Then graph failure available.
Clinically, how do you differentiate between pancreatic pain and biliary colic pain?
Biliary colic, sir, it is usually right hypochondrium, sir.
Very.
And There are bouts of pain, sir. Usually, pancreatitis pain is continuous in nature.
Yeah.
Epigastric and periumbilical in region, sir.
Okay.
And sir,
Usually,
position.
the biliary colic pain it will come in intermittent in nature. Usually, just a fraction of seconds or 10 minutes. It is a crescendo, the crescendo of type of pain, and it will be usually aggravating factor will be like heavy fatty meal food or fat content food will aggravate the pain. So if the patient has got associated fever, then they can like cholecystitis is there, then fever will be there. Whereas your pancreatic pain is a continuous dull aching to moderate to severe intensity of pain will be there. So pain severity, if you compare, pancreatic pain will be very severe pain, whereas biliary colic it will be the mild to moderate pain. Okay. So any other differential diagnosis you wanted to think?
Sir,
One day history, short history. You're telling in your history there is no similar history of pain abdomen. There is no like patient was absolutely normal. Only one day history of pain abdomen and vomiting. So your first diagnosis is acute pancreatitis.
yes, sir. Sir,
Then,
other rare causes, sir, which are very
Yeah.
unlikely, sir, since the patient is
Yeah.
diabetic and pain is also present in the back, radiating to back, sir, it could be pyelonephritis, but there is no history of fever, so it is very
Fever.
unlikely in this patient.
Okay.
Also, it could be, sir, aortic dissection
Hmm.
in
Okay.
this patient, severe pain radiating
Acute
to back.
pain abdomen, yeah, all that they can present in
Yes,
shock
sir.
and all. And
It could be
yeah.
intestinal obstruction with or perforation, sir. But patient does not have any history of constipation or abdominal distension.
Yeah. Still you're in history level, so this can be other possibility. So in history level, you can make out only this much of difference. And one more thing I wanted to ask, in history of diabetes mellitus, since how long? Like she has got diabetes?
Sir, 14 years, sir. Since
14 years.
14 to 14 years.
So you had asked whether our recent diabetes is under control or not.
Yes, sir.
How was her recent diabetic? Like, is it controlled or uncontrolled?
Sir, it is
Whether you asked that,
A1C. Yes, sir.
whether you asked that question or not, whether our
Yes, sir.
diabetic
On presentation, sir, her sugars were around 250 to 300.
No, that's okay. Then I'm telling not like in last 3 months whether our diabetes has been under control or it is uncontrolled.
Uncontrolled, sir. HbA1c was raised, sir, around.
Why it is important? From history wise, if you come to know that patient is a chronic diabetes patient, recently her diabetes is uncontrolled and she is presenting with pancreatitis, clinically you're suspecting pancreatitis. What does clinically it signify? Two things it can signify. Like usually with controlled diabetes, they're presenting with pancreatitis. Recent 3 months, if it is uncontrolled diabetes, then it indicates she has developed pancreatic malignancy. So with pancreatic malignancy, sugars can be very high. That is one thing. Or second possibility, like chronic pancreatitis. Like these are the two important. One is usually around 50 years now. So we should suspect any pancreatic malignancies are there.
Okay,
In history wise, if you ask whether the diabetes is uncontrolled since last 3 months, then even that possibility, like pancreatic malignancy, first time presenting as acute pancreatitis are the chances. Okay. Next. So history wise, you want to think one is acute pancreatitis, peptic ulcer disease, then third is mesenteric ischemia.
And when you diagnose as a differential of acute pancreatitis, you need to, in history, you need to elicit the etiology, try to elicit the etiology of acute pancreatitis. So you need to take a detailed drug history, you need to take detailed previous episodes, you need to take a detailed history of her body habitus, any recent weight changes, all those things you need to try to take an etiology, whether she was an, even though she is female, you need to elicit her habits, whether she is etanolic, all those things. Etiology, you need to make it out in diagnosis when you make it as an acute pancreatitis. Try to elicit the etiology, why it is happening in this case. What is triggering her pancreatitis episode at this moment? So, whether it's biliary pancreatitis, the treatment changes. The cholelithiasis, cholecystitis path changes. So in history wise, you try to elicit the etiology.
So in history wise, can you make out what is the etiology according to your history? Any clue is there? Pooja? Any clue you can make out?
There could be
There is
cause
no
most likely.
so only with
Hypertriglyceridemia will need further evaluation.
yeah, that's what on history wise you are not able to make any because there is no alcohol abuse is not there. And any drugs you asked, what are the drugs causing pancreatitis? Any drugs he is taking?
No, sir.
No.
Nothing significant, sir. She's on.
Which drugs? Yeah, which drugs can cause pancreatitis?
Sir, azathioprine.
Is not taking azathioprine. Then
No, sir. 6 month captoprine. Sir, patient is sir, common drugs for hypertension. Like if patient is on thiazide diuretic,
thiazide. Yeah, that's what.
can cause
It's not
statins
taking.
can trigger pancreatitis, sir.
Okay. Even steroids can cause
GLP-1 analogs, if used in diabetes, they can lead to pancreatitis.
So even steroids, any like steroids, if he's taking
Steroids.
time. Yeah. So in history wise, there is no such history, like drugs he has not taken. So there is no history of alcohol abuse also.
Yes.
And even to tell us that like recurrent acute pancreatitis in your history, there is no previous recurrent history of pancreatitis also not there. So
And, sir, regarding idiopathic or some congenital anomalies, sir, she is a 50-year-old female, so unlikely like
so
any
presenting first
congenital or
time
genetic
usually, yeah.
defects to present in this age, and family history of pancreatitis is absent, so rules out genetic causes also.
Yeah, that is very rare. So usually history wise, alcohol, drugs, and any previous surgeries or like previous history is not there means usually all that other rare causes are very less in this scenario. Okay. Next.
On examination, patient is conscious, oriented, febrile, airway is patent, patient is vocalizing, breathing, patient is in respiratory distress, respiratory rate is 40 per minute, saturation on room air is 88%, use of accessory muscles of respiration is seen. Circulation, pulse is 128 beats per minute, it is feeble in volume and regular, BP is 160 mm of Hg. Capillary blood glucose is 250 milligram per deciliter. Pain, according to visual pain score, is 7/10. Systemic examination, CVS is normal. Respiratory system, air entry is equal on both sides, but bilateral fine basal crepitations are heard. Per abdomen, on inspection, abdomen is not distended, no visible veins or scars seen. On palpation, there is tenderness in periumbilical and epigastric region, but no mass or fluid thrill seen. So, according to after examination, I would like to summarize. So, 50-year-old female who came with acute onset of epigastric pain and vomiting, who presented with tachycardia, tachypnea, hypotension, respiratory distress with hypoxia, could be a case of acute pancreatitis. Differentials being peptic ulcer disease, query perforation, since she is unstable, or it could be mesenteric ischemia. I would like to evaluate the patient further.
So you have ruled out myocardial infarction
From
your first diagnosis?
Yes, sir. Myocardial infarction, sir. Not yet ruled out.
Okay.
Okay, continue.
Sir, ABG was done on room air. pH is 7.3, PO2 is 57, PCO2 29, bicarb 20, and lactate is raised 10.2. Point of care ultrasound was done. Lungs showing B profile in bilateral anterior inferior, lateral inferior, and posterior inferior regions. Bilateral pleural effusion, pleural fluid collection seen. LV function is good. IVC is collapsed, and IVC diameter is 1 centimeter. Basic blood investigations. Total leukocyte count is 18,500. Renal function test, creatinine is normal. Urea is 22. LFT, bilirubin, total bilirubin is 1.2. Direct bilirubin is 0.9. SGOT 234. SGPT 105. ALP 112. GGT is 281. Amylase and lipase. Amylase is 2721. Lipase is 5070.
Okay, just a minute.
Triglycerides.
Just a minute, Pooja. You
Yes,
go
sir.
seeing this LFT, so it is sure that she has got acute pancreatitis. Seeing her LFT, can you tell the etiology?
The biliary most likely, sir.
How do you
Since
say it is a biliary?
sir, since GGT is raised, sir, it could be biliary pancreatitis, sir.
GGT rise means I'm telling even in alcohol something it can be raised. What is the sensitive marker like AST or ALT? What is the cutoff that it shows that patient has got biliary pancreatitis? Usually, according to the studies and all, if ALT is more than 140, then 70 to 80% of the patient it indicates it is a biliary etiology. Like within the presentation on admission and up to 48 hours, if the ALT is elevated, like up to more than 140, then it indicates biliary etiology. It is one of the indicator of biliary etiology of pancreatitis. So in your case, all enzymes are high. Most probably she might have got biliary pancreatitis, or it might be like past of secret stone also. These two things are there in LFT.
Dr.
Okay.
Pooja, based on history, how do you interpret the ABG in this clinical scenario?
Sir, based on history, sir, patient is
ABG. What?
pH is 7.30 acidotic, sir.
Oh.
PCO2 is 29, sir. Respiratory acidosis, sir. PO2 is 57, so hypoxia is present, sir.
So
And
metabolic acidosis with partial compensation, that's what you're implying?
and lactates are raised, sir.
Okay.
So metabolic acidosis, sir.
Okay. And what is your comment on lung ultrasound? You have done the screening ultrasound of the lungs. What were you expecting with this picture?
Sir, ARDS, sir, since we are able to see B profile
Okay.
in the bilateral lung field, sir. Mostly it could be type 1 respiratory failure with B profile in lungs, sir. It could be ARDS.
So there is one
Or
organ.
pulmonary edema.
Okay. So there is already one organ dysfunction with with the suspected pancreatitis. That's what you're now.
Yes, sir.
looking
Yes,
into
sir.
it.
Yes, sir.
Okay.
Organ dysfunction, sir. Yes.
Okay. Can you see whether there is a SIRS SIRS criteria is being fulfilled?
Yes, sir. The temperature is normal, sir.
Okay.
Tachycardia is present.
Okay.
Respiratory rate is more than 20, sir. So 2 criteria are fulfilled. TLC is also raised, sir. 3.
So SIRS criteria she is fitting into with
Yes.
deranged LFT
Yes,
with
sir.
history suspecting pancreatitis. So this is the picture. So based on this, how do you classify pancreatitis at this point of time? Mild, moderate, severe? Or you will take some more time to decide on the grade of pancreatitis?
At present, sir, we cannot comment, sir, because according to Atlanta classification, sir, organ dysfunction needs to be evaluated after, like, sir, around at least 48 hours, sir, will need to know whether it is moderate or severe organ dysfunction, sir.
Okay.
So what are the diagnostic criteria for acute pancreatitis? What are the parameters you are required to diagnose the pancreatitis?
Sir, 3 out of 2 criteria have to be fulfilled, of which are one is clinically patient should have typical
Pancreatic pain you are told.
typical pancreatic pain. Second is biochemical, sir. Amylase and lipase, which should be 3 times the upper limit of normal, which is fulfilled. And third is radiological evidence, either with ultrasound or with CCT.
Oh, fine. So if you've done ultrasound, then it will be sure. Then you can classify according to the what our Chetan told. So what is the significance of SIRS scoring at admission? What is the prognostication you will tell to the attenders? If the SIRS is there on admission and even after 48 hours, what does that implies?
Sir,
what is the mortality rate? Persistent SIRS after 48 hours.
Sir, severity
SIRS,
is useful in
no,
severity.
how do you convey to the patient or patient attenders if SIRS is persisting for more than 48 hours? What is the mortality rate?
Mortality rate.
Or what is the significance of calculating SRS at 48 hours and at admission?
Sir,
He was
more than
asking.
presence, sir, persistence of SIRS has significance in pancreatitis. It indicates progression to necrotizing pancreatitis if it is persistent.
So if they are having persistent SRS, what is the mortality rate usually? 20% of them can have the mortality usually. So that is the important. That's why they asked you, what is the SRS at admission? So if you know the admission and if it is persisting for more than 48 hours, then definitely they will end up in necrotizing pancreatitis. As you know, once they land up in necrotizing pancreatitis, mortality rate is almost 20 to 25%. So you can counsel the patient that it will be in hospital for long term and mortality also will be high. Along all classification like severity score, SRS is very easy to calculate. Other, I think no, all the scoring system are little complicated, whereas SRS is very easy, and you can prognosticate and can tell the attender that mortality is very high, 20-25% of chances of mortality.
Yes.
Dr. Pooja, based on
Yes,
this investigation and ultrasound, what do you think the fluid status of the patient is?
Sir, patient is fluid deprived, sir, with IVC is collapsed, sir. IVC diameter is less than 1.5. So patient is fluid deprived, sir. BP is low, sir. BP is 160.
Okay.
Tachycardia, feeble pulse, IVC collapsed. So it indicates the patient is fluid deprived.
Good pumping function is there.
And sir, screening, sir, LV function was good, sir. So contractility is good.
Another option for USG in this is to look over the gallbladder and look for any gallbladder edema. Those things it is easier if you are able to do it. So if it is an acute cholecystitis induced pancreatitis with the past of stone, you can trigger the pathway towards the urgent cholecystectomy or other further workup for imaging.
Yes.
Okay.
So further investigation, triglycerides and calcium were normal. Chest X-ray was done. It shows bilateral patchy opacities, left-sided costophrenic angle blunting.
Before
ECG
this,
is not.
just a second. Before this, where are you disposing the patient from ER?
Sir,
And
to
what is the
ICU, sir.
criteria for ICU admission in pancreatitis? How are you determining it?
Sir, since patient is having organ dysfunction, sir, cardiovascular as well as respiratory, sir, will manage the patient in intensive care unit, sir.
Unstable hemodynamics, unstable vitals are an indication for ICU admission.
Yes.
Okay.
So ECG is normal. TROP-T was done. It is negative. X-ray erect abdomen was done to rule out perforation. There is no air under diaphragm. Ultrasound was done. Ultrasound reveals hypoechoic bulky pancreas with peripancreatic collection. Liver echo texture is normal. Gallbladder, there is stone is visualized and no fluid around gallbladder or wall thickness seen. CBD is normal. So, sir, severity scoring, sir, BISAP score 2 in this patient, sir.
Okay. So, what is the importance of ionized calcium here? Why you have investigated it?
Sir, to evaluate the etiology, sir, for pancreatitis.
Okay.
Hyperglycemia, hypertriglyceridemia, sir.
Any hormone you would like to also send? Hormone assay?
PTH, sir.
Okay. So another etiology you are ruling out is triglycerides are normal. So you are ruling out another cause of
Yes, sir.
pancreatitis.
So your final diagnosis now, I think you have done all your basic investigation. So your final diagnosis.
Sir, case of acute biliary pancreatitis, sir, who is presented with hypovolemic shock with mild ARDS, sir.
So mostly it is past of CBD stone, I think, because enzymes are high. In LFT, you can see enzymes are high, but in ultrasound CBD, they are written normal. IHBRD is there in
No,
this
sir.
ultrasound. So mostly the past of stone. Otherwise, they will not have so much of LFT derangement. So biliary pancreatitis with past of CBD stone. And as you told, the patient has got organ failure.
Yes, sir.
Dr. Pooja, why
How do
did
you
you choose CT abdomen at this point?
Yes, sir.
Why didn't you choose CT abdomen imaging?
Sir,
He is asking what is the
CT
indication for CT? You want to do CT or you are
now?
comfortable with
Sir,
this ultrasound abdomen?
Sir, I would not like to do CT, sir, at present on admission. CT is indicated if etiology or the cause is not like, sir, we are not
Apparent.
able to get a etiology on admission, sir. But since we have USG report suggestive of gallstones, sir, I would not like to go ahead. If patient deteriorates, sir,
Yeah, good.
after 48 to 72 hours, sir, usually that is the indication for CT. Or
Good.
if patient is old age, sir, around more than 60 years of age, if we are suspecting malignancy in such patients, then we'll
Yeah.
do early CT, sir.
Okay.
Good. Next, continue.
Sir, in initial resuscitation and management, 2 large bore IV cannulas secured. Fluid resuscitation was started. Bolus with ringer lactate at 10 ml per kg. Patient was started with NIV with IPAP of 12 and EPAP of 8 at 6 liter per minute of O2. ABG on NIV was done. It has pH of 7.26, PCO2 of 22, PO2 of 106, bicarb of 18, and lactate of 12.2. Despite fluid boluses, BP remains 82/40 mm of Hg. Patient started with noradrenaline infusion, and fluids were continued at 1.5 ml per kg per hour. Regarding pain management, patient was
No,
given.
just a minute. Regarding fluid only. So what is the fluid of choice? RL you told, no? Why
Yes,
you want to give RL over this NS?
sir, because it is a balanced salt solution. NS, sir, few studies suggested that NS normal saline was associated with normal anion gap metabolic acidosis, sir.
Okay.
So we'll prefer ringer lactate.
Advantage of RL? Why you want to prefer RL? What are the other advantages of RL?
Sir, it is a
Why
balance.
specifically? Yeah, as you told, that is one thing. Next, even I think it has got anti-inflammatory effect also sometimes. So that is the reason they use RL. So as you told, so now you're not giving aggressive fluid management. No? Initially, I think previously we used to go for this early aggressive fluid management. What is the drawback of that? If you give early aggressive fluid management?
Sir, studies have suggested that it does not have effect on the endpoint regarding severity of pancreatitis.
Yeah, correct.
But patient usually lands up in the fluid overload state, sir.
Yeah, correct. And usually there is if you give usually like some 7-8 years back, usually in any case of pancreatitis, they have to rush the fluid like 20 ml per kg body weight initial. Then they used to tell to give around 3 ml per kg body weight fluid. That was the aggressive fluid management. Then according to the recent trial studies and all, they've shown aggressive fluid management will land up in, as you told, fluid overload, and complications are more in aggressive fluid management. So now I think they've changed, and it is like 1.5 ml per hour, kg per hour is a choice. Correct.
Dr. Pooja, when you started fluid resuscitation, what were the end goals of therapy you were looking at or targeting? In the sense, how are you targeting your therapy for fluid resuscitation?
Sir, after starting, initially we'll give boluses, sir. Patient is reassessed, sir, with dynamic parameters, sir, of hemodynamic monitoring. Every 6th hourly, patient is monitored for his fluid responsiveness. Other parameters that we'll look into are blood urea nitrogen and hematocrit.
Hematocrit.
Basically, we will be looking at heart rate and urine output and
Static parameters. Yes, sir.
static parameters and
Yeah.
dynamic
Yes, sir.
parameters. If you are having invasive monitors, you can definitely pull it up.
Yes, sir.
So you will be having goals of therapy where you will be starting fluid resuscitation and urine output, whether you will be inserting catheter, Foley's catheter.
Yes, sir.
Why?
Sir, since patient is in shock, sir, on vasopressin and fluid, sir, will monitor urine output, sir, in this patient.
And that's also one of the indicators of fluid therapy, whether urine output is adequate or not. So you'll be starting based on these ideas when you're starting fluid resuscitation. So there are a couple of studies where they started with 5 to 10 ml per kg and 10 to 15 ml like that kgs. They found 5 to 10 ml per kg was initial resuscitation was favorable compared to 10 to 15 ml per kg of resuscitation. So how often you will monitor in ICU, like when you're starting fluids in this particular acute pancreatitis?
Sir, 6th hourly, sir.
There is no such a random time frame where you will be looking, you will be doing a continuous assessment.
Yes.
Intermittently, you will be seeing for the response.
Yes, sir.
Okay.
Pooja, why
Yes,
is hypotension in this patient? Why?
Sir.
Why?
Sir,
And
because
they have
of
started.
third
Yeah.
stage fluid loss, sir, in pancreatitis, sir.
No, you corrected fluid deficit also. No, you've given this loading dose and all. You have started fluid. With that also, patient is having hypotension. You're happy with that, like patient fluid loss, hypotension, or what, or any other component is there for hypotension?
Sir, we'll have to evaluate for sepsis, sir. Any extra pancreatic source of infection or sir,
Extra
pancreas
pancreatic, why you
itself,
want to think?
or pancreas itself is a source of some infective necrotic pancreatitis, sir.
Because our counts was high actually, initially some 17,000.
Yes, sir.
And persistent hypertension, you want to think of it is because of sepsis or what? This hypertension?
Yes, sir. Yes, sir. Sepsis induced, sir, since lactates are high, counts are raised, and patient is not responding to just fluid resuscitation, I would like to consider sepsis as one of the differentials, sir. And patient has good LV function, so no cardiac involvement as such.
Okay. Okay. Then next.
Pain management, patient was started with intravenous paracetamol 1 gram 8th hourly and tramadol 50 mg 12th hourly. Patient was kept NBM. Blood sugars were maintained between 140 to 180 mg per deciliter using actrapid insulin. Diagnosis of acute biliary pancreatitis with hypovolemic shock and mild ARDS was made.
Why do you think a patient was having hypovolemia in this particular case? She has only one episode of vomiting.
Sir, because of third stage fluid loss, sir.
Yes.
Because of pancreatitis. And patients, sir, usually patients will have multiple episodes of vomiting that could lead to fluid loss. Patient will usually have decreased oral intake that will lead
So
to
inflammatory response from pancreatitis will lead to third space loss. So that you need to make up with your resuscitation. And what is the pain management goal here? You are initiating with paracetamol with pain score of 7 by 10. Whether this is adequate and how aggressive you need to do pain management in acute pancreatitis on admission.
Sir, will consider, sir, stepping up, sir, towards opioids, sir, if it is not controlled with intravenous boluses, sir, first we'll try. If not controlled, then we can go to continuous opioid infusion.
What
And
advantages does the pain relief have in initial within 24 to 48 hours? What advantages in this particular case will give with aggressive pain management?
sir, usually aggressive, sir, abdominal pain, sir, it can cause, it can worsen the respiratory distress, sir, because of basal atelectasis that is due to severe abdominal pain. So, sir, pain management can help in respiratory component also, sir.
Yes, splinting of diaphragm will be prevented with adequate pain analgesia. So if patient is also with NIV, so in diaphragmatic splinting will be prevented with adequate pain analgesia, pain relief.
So Pooja, you have started with antibiotic on day 1,
No, sir.
but you are telling you are suspecting sepsis and all.
Sir, I would first like to confirm, sir, like,
How do you confirm sepsis?
sir, with procalcitonin and
Hmm.
sir, clinically patient is not having fever at present. So
Okay.
I'm not considering it as this thing. Sir, will go
So
ahead
that's what
with serum
I got a
procalcitonin.
fine. See, in a simple acute pancreatitis or biliary pancreatitis, there is no role of empirical antibiotics. There is no role actually. Only if you're suspecting like sepsis, hypotension and all, then you can give empirical antibiotic till your all the reports are vetted. But as of such, like there is no role of empirical or prophylactic antibiotics in case of acute pancreatitis.
Yes.
Okay.
Day 2, sir, patient had mild pain and respiratory distress had decreased. ABG on day 2 is pH of 7.39, PO2 of 68, PCO2 32, bicarb of 29, and lactates were decreased 5.4. On day 3, patient developed fever, tachycardia, abdominal pain. On examination, patient had slight epigastric distension and tenderness. Airway is patent, vocalizing. Respiratory rate was 42 cycles per minute. SpO2 92% on NIV with IPAP of 10 and EPAP of 6 with 6 liter per minute of O2. Circulation BP is 160 mm of Hg on noradrenaline infusion and IV fluid at 1.5 ml per kg per hour. CBC was repeated on day 3. The total count had increased. ABG on day 3, patient had pH of 7.22, PO2 of 88, PCO2 of 23, bicarb 19, and lactates were raised 11.2. LFT was also repeated. Bilirubin was 2.9, direct total, direct 1.7, SGOT 442, SGPT 389, ALP 251, and GGT 563. Culture was drawn, blood culture was drawn, serum procalcitonin was sent. CECT was done on day 3. It shows diffuse bulky pancreas with large non-enhancing area, 60 to 70% of necrosis, peripancreatic fat standing, ill-defined fluid tracking along bilateral anterior pararenal space, minimal ascites, minimal bilateral pleural effusion, feature suggestive of acute pancreatitis. CT severity score was 10 by 10. There is evidence of cholelithiasis. There is no intrahepatic biliary radical dilatation. CBD is normal.
See, Pooja, this one confusion is there. See, LFT is same of this patient only. Usually, if CBD is normal, LFT should have this improved actually. You written ALP is high, everything, so it is not matching. Here you're telling in CT, CBD is normal. There is no AH PRD. I think LFT, are you sure? We go back to the previous slide. LFT have written so high values. I think that might be the initial reading, I think. Previous slide.
Yes, sir. Not able to.
There you have written high values. AST also was some around 400, 300, ALP 250. I think this is the this first reading, I think. Very unlikely. It is not correlating actually. See, if it is CBD still normal, then it should not have such a high value. Okay, you just see once. Fine. Next.
I'll go.
No, yeah, just see the values.
Patient was started with intravenous piperacillin tazobactam 4.5 gram IV 8th hourly. On day 4, we received serum procalcitonin. It was raised 2.2.
Previously, There are two trigger points. Previous slide, you went for abdominal imaging at this point of time,
Yes, sir.
right? And second trigger point was the starting of antibiotics. And what made you do this? What was the reason for these two? What
Sir, on day 3, sir, patient developed fever, sir, and his pain worsened. So, sir, that was the trigger for imaging, sir.
So
Yes,
recovery is not happening. There were new onset of
New
symptoms.
onset of symptoms, sir, and the total count was raised, sir, 21,000. So, sir, suspecting deterioration, sir, we have done CECT on day 3.
Okay, fine.
And antibiotics?
Sir, suspecting infected necrosis, sir.
Okay.
We have started
you-
empirical antibiotics, sir.
Fine. So you're telling there is a necrosis and you're suspecting infected necrosis. On that background, you started antibiotic.
Yes, sir.
So that's fine. So how do you classify all these peripancreatic collections usually? What are the standard definitions?
Sir, according to
Yeah,
Atlanta, sir,
yeah. Tell me.
Atlanta classification 2012, sir. Morphologically, they have classified pancreatitis as interstitial edematous pancreatitis.
No, I'm telling peripancreatic fluid collections. That's all.
Peripancreatic fluid collections, it can be pseudocyst, walled off necrosis, acute necrotic collection, sir,
Okay. Then
and acute peripancreatic fluid
peripancreatic
collection. 4.
collections. So how do you define all that things? So in
Uh,
your case, it is walled off necrosis or what? Or just a acute necrotic
It is
collection?
acute necrotic collection, sir. Acute necrotic collection is usually associated with acute necrotic pancreatitis of less than 4 weeks duration.
Okay.
More than 4 weeks, when a definite wall is formed, we call
Walled
it
off necrosis.
walled off necrosis.
So in your case, it is a acute necrotic collection. ANC
Acute
is a
necrotic
acute necrotic collection. Whether
Yes.
it is infected or sterile, actually in your history wise, since he has developed fever, procalcis high, and all the things, so it is assumed, like you need not prove
Yes.
it, like you need to do FNAC and all. Clinically, you can suspect it is an infected acute necrotic collection usually. So on that background, you have started antibiotic.
Yes, sir.
Next.
What do you CTSI, or can you tell
Modified.
more,
Yes, sir.
more about it?
Modified CT severity score, sir. It has got 3 parameters in it. One is pancreatic necrosis, pancreatic inflammation, and local complications, sir. One is pancreatic necrosis is graded as 0, 2, and 4 score. 0 means no necrosis. 2 means less than 30% of pancreas is having necrosis, and 0 to 4 is more than 30% necrosis. Pancreatic inflammation is again classified into 0, 2, and 4, sir. 0 means no local complications. 2 includes intrinsic pancreatic changes with or without peripancreatic inflammation. 4 includes definitive intrapancreatic inflammation along with peripancreatic changes. And third parameter is the local complications, which could be pleural effusion, ascites, vascular complications.
So basically in the CT scan, they are looking at how much the dye is being distributed. That defines the necrosis. This second is morphology, how the pancreas is appearing on the CT. Based on 2, they're along with the other side complications of the pancreatitis. That is how they're, in simplified way, they're grading it.
Yes. So maximum score is 10, sir.
So he had the maximum grade of pancreatitis. That's how we are defining now.
Yes, sir.
So now the definition of the diagnosis is severe pancreatitis
Acute necrotizing.
with
Severe acute necrotizing pancreatitis, biliary pancreatitis.
with
very
persistent cysts,
Sorry, sir.
with persistent cysts. SIRS?
Yes, sir.
SIRS,
Persistence of
persistent ARDS.
SIRS and mild ARDS, sir.
So SIRS has persisted more than 48 hours.
48
in this
hours,
case.
sir.
So what grade it will be? Acute, severe?
Severe pancreatitis, sir.
So prognosis is?
Poor prognosis, sir, with
No, should not tell. You should tell
mortality,
Mortality rate?
sir.
initially only you told 25%.
With SIRS persisting around 20% mortality, sir.
So SIRS we are not able to control still. Inflammatory response we are not able to. The body is still persisting with the inflammatory response syndrome.
Yes, sir.
And what made you choose peptides in this?
Sir,
Antibiotics?
usually, sir, will choose antibiotics for gram-negative cover, sir, and those which will have penetration in the necrotic tissue.
Okay. Based on your
No, he's
local.
telling, Dr. Chetan is telling what made you to choose piperacin tazobactam. Why not meropenem? Why not ceftriaxone? He's asking you. What is the rationale?
Sir,
Why not you are given meropenem?
sir, since suspecting gram-negative sepsis, sir, in this, so I've started with piperacillin and tazobactam, sir.
So you should know this bacteriology in acute pancreatitis. What is the most common bacterial associated? Then accordingly you should give, no? That
Sir,
was his question. Why not you are given meropenem? Why you are given piperacillin?
Sir, E. coli, Klebsiella are common organisms, sir, associated with infective necrosis. Sir, and carbapenems would have been a better choice, sir, since they have better penetration in pancreatic necrotic tissue, sir.
No, you'll have the protocol, no? You'll go for step up or step down like that. So whatever like your ICU protocol you can follow. It's not like a hard and fast rule like you have to start meropenem or piperacillin. This is your ICU protocol. And what about the nutrition? Since last 3 days, how have you taken care of nutrition?
Sir, patient has been, so since the pain is increased since 3rd day, sir, we have kept the patient NBM, sir.
So nutrition, how you have taken care of nutrition?
We'll consider, sir, once the pain reduces, sir, we can consider starting enteral nutrition in this patient, sir. Oral.
So this, yeah, I got, since a patient has got severe pain, you have not started orally. So enteral nutrition has not started. So is there any role of parenteral nutrition?
Sir,
Is
it is
advocate?
usually not preferred, sir. Most preferred will be oral route. If not that, sir, enteral, either nasogastric or nasojejunal, both are.
No, you want to give nasogastric or nasojejunal? Both two entities are different.
Nasogastric will prefer, sir, since nasojejunal, sir, it is difficult to, sir, it will require endoscopic assistance. It will require radiologic and endoscopic assistance, sir.
See, what is the advantage of nasojejunal feed or nasogastric feed?
Sir, gastric stimulation that occurs with nasogastric feeding that can increase the worsen pancreatitis, sir. So
still you want to give
theoretically,
gastric feed? Theoretically, see, that's what. See, if you are giving nasogastric and to stimulate the pancreatic secretion, no? So it is always better to have nasojejunal. So you are bypassing the pancreas. So stimulus to pancreas will be less. So nasojejunal feeding will be, means if you assume that patient has got persistent pain after 3-4 days also you are not able to feed him. So then you can go for nasojejunal feeding.
Okay. And nutritional requirement, whether it will be increased in this phase? How is your calculation of the nutritional requirement, calorie requirement?
Sir, around usually, sir, 25 to 35 kilocalories per kg, sir. But since it is a catabolic state, we'll go for target 35 kilocalories per kg, sir.
They are hypermetabolic. catabolic state. So you need to adequately increase the caloric requirement. So once the pain control is there, you can start orally as early as possible. That is one of the things that helps in acute pancreatitis. So previously, many people were put on NPO regimen for acute pancreatitis, but nowadays we are starting on early enteral feeding. And TPN is complementary to enteral nutrition. Complementary in the sense you need to target the caloric requirement. So if you are not able to achieve enteral nutrition, you need to complement with TPN. And how do you start enteral feed? Like what rate? How it is? If you are able to orally, you are able to manage, means it's okay. Oral self feeding. If it is through enteral tube, like nasogastric or nastrojejunal, how are you starting? What regimen you are planning?
Sir, we'll start with around 50 ml per hour, sir, feeds.
So it will be continuous feed that is more beneficial rather than intermittent boluses in these cases.
Next day. Okay, fine.
CT images. On day 4 and 5, the treatment was continued with IV antibiotics, NIV, IV fluids, noradrenaline, was gradually tapered. On day 6, the pain decreased, vomiting, fever, respiratory distress had come down. Patient was off vasopressors by day 6, and oral soft diet was started. Patient was weaned off NIV to O2 by nasal prongs, 2 liter per minute, and he was maintaining a saturation of 92%. On day 6, ABG was pH of 7.34, PO2 of 89, PCO2 of 38, bicarb of 28, lactate of 1.2. Total leukocyte count was 11,000. LFT, sir, improved, the enzymes were decreased. Blood culture we obtained, there was no growth in the blood cultures. So, sir, after on day 7, sir, patient was shifted to ward.
So you have successfully managed necrotizing pancreatitis in 7 days. Whom do you attribute the success to? Fluids, antibiotics, ICU care? What do you attribute the success to?
Fluids, sir, and antibiotics.
Fluids or antibiotics? You given initially fluids for 2 days. He has not improved, no?
Antibiotics, sir.
So what is the role of fluids in early management? You are receiving patient acutely. So fluids, as sir told, it decreases the inflammatory response. We need to target the inflammatory response here. So probably your aggressive fluid response or fluid resuscitation helped initially. Then patient had a sort of infection which sepsis, probably that was managed with antibiotics, probably. So both were dual. And the natural history of acute pancreatitis is for up to 7 days to 14. Around 7 days, patient will generally settle if there is no other complications. So probably natural history also helped in settling of the syndrome. So you will attribute success to all three and yourself.
So discharge the patient or your advice for cholecystectomy?
Sir, we'll follow up the patient, sir. Since patient is having necrotizing pancreatitis, we'll wait for the necrosis to heal, sir. Like by 4 weeks, develop walled off necrosis. And
again,
after
there is
that,
again there is some controversies are there. See, in this situation, because of biliary pancreatitis only, all this pancreatitis have happened. So if you give a lot of time, again, if they have second episode of pancreatitis, then it will be very sick also. So when do you advise cholecystectomy? Like before discharge, or you want to follow up after 6 weeks?
follow up, sir.
That's what there are two school of thoughts.
Okay.
Usually, if you think that LFT has subsided and if you are sure 100% that there is no Sibley stone, before discharge, you can get the cholecystectomy done. Because if the patient develops second episode of pancreatitis within 2-3 weeks, then it will be very severe.
And when will you involve the surgical colleagues here? Surgical team reference. Pain abdomen was there.
Sir,
Acute
since
abdomen.
it is sir, we are suspecting infected necrotic
Yes, sir.
pancreatitis here. If patient is persistent, hemodynamically unstable, sir, he'll require surgical intervention. So, sir,
What surgical intervention?
sir, minimally invasive approach, sir, to drain the necrosis, sir, infected necrosis.
Nowadays, we don't do
using minimally invasive.
surgeries and all in acute necrotizing pancreatitis. Nowadays, nobody does actually. See, you're telling within 1 or 2 weeks, nobody does surgery for pancreatitis, no?
Pancreas has to be seen, not touched initially.
Sir, if not in this case, sir, but if pancreatitis is associated with cholecystitis, sir, then patient will require emergency intervention, sir. He'll require ERCP.
You ruled out bowel perforation, and if there is because of fluid resuscitation, there may be abdomen compartment syndrome. That time you need to refer.
Sir, in presence of vascular complications.
And gastric outlet syndrome may occur because of necrotizing, or the bile duct may tear off because of necrotizing. Those things, it is generally after 4 weeks. Acute settings only ischemia, perforation, or acute compartment syndrome of the abdomen. That's where surgical colleagues will come.
Next. Okay, just a hypothetical question. Like in this case, in your case, if patient had persistent fever, you're telling them almost second week of pancreatitis, no? Patient is going. You're given antibiotic of piperacillin and all. So patient had persistent fever. What do you want to do? How do you manage?
Sir, despite of empirical therapy, sir, if he is not responding, sir, one is we can consider fungal involvement, sir, since patient is diabetic.
No. First is you have to change the antibiotic. No, you are given for 7-8 days. You are given. So you want to
escalate,
escalate the antibiotic. You change. In spite of that, also, if he's having fever.
Sir, any
so you want to. You told antifungal. You told you want to add antifungal. That's fine. In second week, fungal infection can happen. So you added antifungal. In spite of that, also patient is having fever. So many cases you have seen, no?
Extra pancreatic, any infections, sir, will have to reevaluate the patient for any extra pancreatic source.
So you have got already pancreatic necrosis. Why you want to think about extra pancreatic infection? See, in this patient, he already has got pancreatic necrosis is there.
Yes, sir.
It's infected. So how do you manage? So you are given antibiotic, adequate antibiotic, antifungal you are given. Still second week of pancreatitis.
Sir, will consider surgically, sir, CT-FNSC to.
No. CT-FNSC, why you want to do? See, FNSC, it is you are confirmed that is a infected necrosis, no? So I'm asking, how do you manage infected necrosis in day, like 2 weeks of second week of pancreatitis?
Sir, if patient is not improving, then he might require drainage, sir.
Yeah, tell drainage, that you should tell, no? Correct. How do you drain?
Minimally invasive approaches are used.
I think you are fond of surgery. I think you will always telling minimally invasive surgery. See, surgery nobody does in pancreatitis unless it is more than 4 weeks. So less than 4 weeks, all intervention radiology or medical gastro, they will manage the scenario. So you're telling drainage of the necrosis or abscess. How do you drain it? What are the modes of drainage?
Sir, endoscopic method, sir. Lamps.
See, there are 2 ways.
Drainage,
one is, yeah, if one is like patient is very sick or cachexic or you are not able to move the patient, then you can go for percutaneous. As you told, CT guided pigtail insertion, not aspiration. If it's possible, you can put a the pigtail to the abscess or necrosis. That is one modality. Or if you think there is already like well-defined wall is there, then we can go endoscopically. Through endoscopically, we can do the US and we can see whether we can drain all the abscess. We can put the stent and all. Usually you're telling second week, third week means all will be thick walled, thick capsules will be there. So we have to put the metal stent. As you told, lamps you have to place.
Yes, sir.
Or if it is very thin, and we can put the plastic stents. These are the two ways of managing the abscess or this necrosis. One is percutaneous mode, or second is endoscopic mode. In endoscopic, one is plastic stent or this metal stent. So surgery nowadays nobody does for acute pancreatitis less than 4 weeks. So told if it is more than 4 weeks, it has formed pseudocyst and all. If patient is not willing for endoscopic management, then only you will send him for surgery. Or if endoscopic management is not feasible, especially if the pseudocyst is in the tail of the pancreas, where we cannot access the pseudocyst, then you will send him for surgical management.
Okay, Dr. Pooja.
Yes.
It was a wonderful case presentation. You are presented very lucidly, and it was quite exciting to participate in the discussion. I thank Dr. Vijay Kumar, Dr. Jnanamani, Dr. Raghunath, and other distinguished faculty and participants of this case discussion. If there are any questions, you can please unmute yourself and ask. We have another 2 to 3 minutes remaining.
One question is there in the chat. Hello.
Yes, sir.
In the chat box, one question is there, like anti-diabetic medication such as sitagliptin can cause pancreatitis.
We have not seen any case, but I went through the
So-
literature. It has defined.
That depends on temporal association, sir. If you're attributing drug-induced pancreatitis, first is a temporal association is very important. If it was introduced recently, then we can think of that. If patient is taking since last 2-3 years, it is unusual to cause pancreatitis.
Thank you. I have one addition to this patient as a critical care point of view. As Pooja was mentioning, IVC diameter 1 centimeter and all, we should not consider any diameter while research to the patient. It is the IVC collapsivity index. If you really want to take the that parameter, it is not the diameter. Don't take diameter. Second point is, in spite of day 2, day 3, patient is still tachypneic on NIV. So any patient on NIV, tachypnea is there, more than 37, 40 was there, I think, in that case. Better to intubate. At least we can wait for 4 to 6 hours, not more than that. Intubate, ventilate, resuscitate the patient, then extubate whenever the patient recovers. Continuing NIV is not advisable when there is still tachypnea percent on NIV, especially such acute pancreatitis, such patients. That is one addition to this for the case management.
Thank you, sir.
Thank you, Vijay sir. It was excellent
Thank you, sir.
discussion. We really enjoyed each and every point was highlighted actually. It was a great
Thank you, sir.
discussion. Dr. Chetan, it was really a great discussion. Thank you so much. I think if we have discussion like this, many doctors will get, more advantage of this, and they'll put their thoughts in the management of the cases, such difficult cases. Thank you.
Thank you, sir.
Aishwarya, if you want, you can conclude. Yeah. Unmute. Unmute, Aishwarya. Okay. Anyway, thank you, Dr. Chetan sir, Dr. Vijay sir, and even Dr. Pooja done well, and Dr. Jnanamani for your presence and sharing your thoughts. Thank you so much, and thank you, Remedy International, for continuing, saying me like this case discussion really helpful. I think more all doctors and are asking for case presentation rather than presentation of any disease per se. I think we'll concentrate more and more case presentation.
Cases.
Involve expertise like Vijay Kumar sir and all. really we can take more advantage of out of them. Thank you, one and all. Thank you.
Thank you, sir.
Shravya,
Nice presentation.
thank you.
Thank you so much, sir,
Thank
for
you.
the opportunity. Thank you, sir.
Thank you.
Thank you, one and all. Let them. Should talk loudly. This is the mute.